trial and the global leaders trial, they've shown that if you want to go back to single ticagrelor use twice daily after 1 to 3 months, that is a reasonable choice that you can have. And for long term, then you switch to 60 BID, depending on your DAP score and your Has-Bled and bleeding scores, precise DAP scores that you can calculate, and given based on that, decide the long-term usage that needs to be done or not. So this drug, I think, especially with prasugrel also not being around, I think it's a superior drug. Clearly, the data shows for all outcomes in plateau that we're all aware of, so we should push it further. Now, a question whether in the initial phase where there's rapid onset, we should use that, and then maybe later on, switch to that. The curves continue to diverge in the plateau trial throughout, during the first month and later on as well. But the most divergence of curves and the benefit seen is in the early phase, in the first 2 days and then the first 30 days. So yes, that is not an unreasonable choice. That is an expensive drug. So the first month of ACS, maybe you use that for our population, where you have cost constraints and all that. But at least for the first month, where you get the maximum bang for the buck, in that scenario, to use it for the first month, and then because of the cost constraints later on, if you want to switch to clopidogrel, you can do that. That is not a bad thought. That in the initial phase we do that.
Thank you, Professor Nouman Nasir. We again go to Peshawar, take 2 comments, but now Peshawar people have to be very brief and summarize because their previous turn was missed. So again, Professor Amber Ashraf, if you are with us, can give comment, and we'll take Dr. Ahmed Fawad as well. So both of you can make some comments regarding the subject going on, your experiences, and then way forward how to incorporate ticagrelor in our clinical practices. Yes, Dr. Amber Ashraf. And if again having some problem, Dr. Ahmed Fawad, you can join us from there, Peshawar.
Yes, Fawad, thank you very much. Can you hear me?
Yeah, we are hearing you.
Right, okay. As far as this molecule is concerned, if you see the guidelines, ACC, they incorporated this molecule as a 2A indication in 2016, I think. And ESC then in 2017, they went ahead and class 1 indication. So as far as the indication and the confidence is concerned, I've been waiting personally for this molecule to be available in our country. So there is no doubt. It might be a new molecule for us, for this population, but I think people in West and particularly in states and in European countries, they've been using for the last 4 or 5 years. So for all my ACS patients personally, I have shifted them to ticagrelor, 90 milligram BD, 180 milligram loading. There's no doubt. And my stable CD patients, yes, they still remain.
And Dr. Ahmed Fawad, when you're saying ticagrelor, you're using the generic one which is available?
Well, as far as the choice of ticagrelor is concerned, I think we 4 or 5 months ago we didn't have a lot of choice. I think PharmaEU and a couple of other guys, they have formulated this molecule. So we are familiar with the NPLAG and we are familiar with Virata so far in our cath lab. Particularly those patients who are in ACS and cath lab, they routinely go on these 2 molecules. Particularly living in a society where the South Asian population, one study showed up to 38% resistance to clopidogrel. Personally, I believe that this molecule may be solution for our population in a low responder group. My main question and worry remains, and particularly I would ask Professor Hafiz experience if he has been using this molecule for some time. Have you seen any person with a ticagrelor post angioplasty and coming back with a stent thrombosis?
I think we can take these questions to the other panelists who are using that as well, and we'll take Professor Hafiz's opinion on that as well. So I'm going to Islamabad, and in Islamabad we have Asad Ali Salim. He's HOD Shifa, and if he will be joining us from the Zoom link. So shifting this question to Dr. Asad Ali Salim, Have you seen any patients with stent? Certainly the reason for implantation issues, keeping aside, just for sake of the person who's perfectly stented, no issues with technical issues, and he got stent thrombosis with ticagrelor. Yes, Dr. Asad Ali Salim. I think there are some.
Can you hear me, Fuad?
Yes.
Fuad, I did not hear my connection was bad. I did not hear your question.
Okay, I'll repeat the questions. Are you using ticagrelor in your routine practice?
Yes, Fuad, I have to be honest, I was a bit afraid when it came up.
Okay.
And I did not use it initially because, the stakes were very high. Stent thrombosis.
So after using it, have you seen any of your patients without any technical problems, just with this drug and everything was perfect, and any stent thrombosis?
Let me tell you my experience. So I initially did not use it, and I was a bit afraid. Then two of my colleagues, because stent thrombosis is a very bad event, devastating event. So I was afraid of whether the drug is as effective as they claim. So two of my Dr. Azim and Asad Akbar, they came along and they started using it. I kept on looking at them, their experience, how I was working in the same lab. I waited for at least 3 to 6 months before I took it up, and I'm using it now. First line drug, a good experience. Another thing that very beneficial, as I also told us, in some patients, who are not low, we crush it, we crush it, and study which says the effect is very quick. So I'm using it much more frequently now. In fact, as a first line drug, it should be used as a first line drug.
Our question is still there. Have you seen any stent thrombosis?
I have not seen, frankly, for the last 1 year I've been using it. I have not seen any stent thrombosis. Most of the side effects are shortness of breath, and if you explain it to the patients, and headaches are another side effect. But if you explain it to the patients, and in a month or so, and they understand. I told them that you have to use it. It's very good for your stent, for the patency of your stent, and they seem to. And after about 2 to 3 months, I switched them to Plavix. A lot of
Okay, thank you. Thank you, Asad Salim, for your comments. We are again coming back to Karachi, and we are left with two experts here in Karachi. So I'm just now concluding the session. As such, we take all the person who are left. Again, turn-wise from Karachi, Peshawar, Lahore, and Islamabad. And here in Karachi, we have with us Professor Tariq Ashraf. Sir, you have to say something about the subject.
Yeah, thanks, Fuad. To start with, Plavix came into the field for angioplasty in Pakistan. It was very costly, so with a CLAP ISD was done, in which low plat was compared with Plavix and found it to be of equivalent efficacy. So we started using low plat for angioplasty, and interestingly, low plat was being used as a BD dose for 1 month, and then it was continued onwards. But in spite of giving low plat BD, we came across with stent thrombosis. So we were afraid what's going on. So when ticagrelor came in, so a patient with stent thrombosis, after aspirating and ballooning the stent, so we put the patient on ticagrelor, and then with experience we came on that in patients who underwent for primary angioplasty, I usually give a ticagrelor on the table and do a procedure and continue for about 3 months. And then if the patient thinks about any issues with ticagrelor that have come across, other than dyspnea, is in some of the patient with ecchymosis. So I stopped ticagrelor, and after about a month or so, then put the patient on clopidogrel. So ticagrelor locally as bioequivalency has been done with Brilinta, so in complex angioplasties, long stents, so I think it's a good alternative, having a very cost-effective.
Thank you, Professor Tariq Ashraf. I think there are so many people and everyone to give his input. Since now we are going just from Professor Tariq to Professor Nawaz, we'll come to everyone. So you can, if you have thing previously in your mind, you had to add on something, you can add on. So Professor Nawaz, anything about it, and then we'll go to Lahore to take comment from Dr. Tayyib Muhibbuddin and Dr. Javed Ashraf as well. Islamabad is left, Dr. Akhtar Ali Bandeshah, and in Peshawar we have to take few comments as well. Yes, Professor Nawaz.
Thank you, Dr. Fawad. This is actually a wonderful session. It's virtual. And Pharmio company, they did some good thing in the form of bioequivalence, because this is the first step to enter the drug in the body, and that's we call the bioequivalence. But still this needs the pharmacodynamic effects of this drug in the form of efficacy and the safety. So hope they will do, and the facilities, I think Karachi University is doing, starting the clinical trials also. So far I'm working in the private as a public university hospitals. Generally, I have faced the two problems in prescribing this drug. No doubt this drug is used in sense that there are 20% of the patient, they are resistant to the clopidogrel. So, and this effect, resistance is more seen in the patients, especially diabetic patients, LV dysfunctions, and acute coronary syndrome. So keeping this thing in mind, and keeping other things, the price and availability of the drug. So I always start my, if patients are high risk, I always start with the ticagrelor, at least for the 2 months, and keeping this thing in mind that patient will buy. So we are either, we ask the patients, go and purchase this medicine at least for the 2 months, show me, or we can arrange this medicine for the patient, and then we send this patient to home. Because as you know, if you don't give the clopidogrel and you started the ticagrelor, but he is not buying, or if it's not get, so it's a prognosis worse in these patients instead of giving the clopidogrel in these patients. So generally what I do, this is the clopidogrel for 2 months and then switch on the ticagrelor for 2 months and switch on the clopidogrel. But if patient is low risk, I can keep these patients on the clopidogrel, and they are doing well. So this debate actually is to give the general message to the general other doctors to whom these patients also visits, because they came to the very busy hospitals. The doctors, they do the angioplasties, and then the patient leave and they go to the other doctors, which doesn't know about the importance of the drugs. And sometimes they can stop their drugs, say that's costly, don't take this medicine, or there are suppose there are bleeding issue, they stop, but they can't counsel. Same like suppose patient develop the dyspnea and they start the antibiotic and so on, but they doesn't know the side effect of the drugs. So simple counseling, switching and drugs, and so this is, I think, the great platform to give awareness about the ticagrelor in the other doctors which are not in direct contact, they are doing the angioplasty. So thank you very much for the Pharmio company, and thanks Dr. Fawad and this panel of experts. They came here and then we shared the knowledge with each other, and we send this message to the other doctors who are joining us in the as a virtually. I just taking the opportunity to just do some announcement that we are doing the PHL conference in the Karachi. I hope there are so many seniors, they are sitting here. So kindly do convey this my message to your juniors, students. They come and participate, especially in the research. They can present their posters, and then thank you very much, sir.
Thank you, Professor Nawaz.
September 26th.
Okay.
Yes.
Tayyib and Dr. Javed, actually we are overshooted from the time as well, and it's really very difficult to manage that much experts and to provide opportunity to everyone. I think they have left because of time constraint. But I think we have with us Dr. Akhtar Ali Bandeshah from Islamabad. Can you have some words to say? Dr. Akhtar Ali Bandeshat from Islamabad. And lastly, we'll go to Peshawar again, and then finally concluding remarks from Professor Hafizullah Saab if he's there. Yes, Dr. Akhtar Ali Bandeshat.
Thank you very much, Dr. Fuad. This is my personal experience. Actually, I would like to highlight few experience and few points. One is that I always I'm very confident to use these drugs, the newer drugs, which come with some guidelines actually, and the world has the experience with those. So I started Prestogel in 2012, 11-12 once in Pakistan, and the results were same. With us, there were relatively more bleedings in our patients. So we got a bit skeptical and came back to clopidogrel. And I started using this ticagrelor in 2 years back once the CCL and this Farmigo, they brought in these medicines. And one of my patients actually, whom I did intervention, it was LED diagonal bifurcation stenting, BK crush. And the patient was put on an flag or ticagrelor or whatsoever was available at that time. And the patient was from, not from Islamabad, it was from some other city actually. And one day, a cardiologist from there actually calls me that the patient had chest pain and is having chest acute ST elevation MI. And I knew that this is stent thrombosis. And I asked him to give him thrombolytics, and then the changes happened. Then I did his angiogram again, and there was thrombus. But the problem was not with the Hello. So the problem was not with the drug; it was the availability of the drug. So if Farmigo or any other company comes, then definitely the quality of the drug matters, and then the distribution and availability, and how to educate the patients, that is important, because a patient who is spending a lot of money on 2-3 stents will be able to buy that drug as well, but he does not understand the importance of that. He says that I was using 10, 7, 8 drugs, so if one is missing, that will not cause any problem, but that's not the case. So the drug, I think, as Professor had mentioned, that Eastern paradox, I do believe that generally we are the same, because from aspirin to the ticagrelor, there is a long journey, 20-25 years. Use of these antiplatelets in different ACS and interventions. And we know that the experience, our experience generally has been the same as it was in the Western world and the rest part of the world. So this is my comment.
Thank you, Dr. Akhtar Ali Bandesha. Now we'll go to Lahore. There was a misconception. I got a message that Dr. Tayyib Mohiuddin and Dr. Javed Ashraf left. So I thought they have left the arena. So they are left in terms of move on to both of them. I'm very sorry that I went to Islamabad. Yes, Dr. Tayyib Mohiuddin, very anxiously, maybe waiting for a very long time. So I want your comments.
Not at all, actually, not anxiously waiting, but I was just like, I'm very much sitting here. So most of our colleagues have actually, described everything. You know, I don't think there's a debate anymore. This is a class 1 approved drug now. It's a preferred agent for non-STEMI. Most of the guidelines have shown this to be a superior molecule, superior drug for us. I think this debate kind of helped me at least today, because listening to people from Liaquat, listening to Asad Akbar, listening to Asad Salim, you know, I have the same reservations as Asad Salim. So coming here today kind of helped me the most. You know, this drug has made it to most of the guidelines. All of us know from Plato trial, the number needed to treat was only 52. So this has been there. This has been a proven drug. The only problem is within our setup, we had this inertia or difficulty in starting writing ANFLAG as compared to Berlinta. So now we have the BE study. We have listened to all of our colleagues with their wonderful experience with much less stent thrombosis, less side effects. I wish the Liaquat would publish their study. I think this will, or even Shifa International must have used in several patients. This would help people like me or others to start using ANFLAG. Ticagrelor, we are sure, we know that this is the way forward. Other than some of the side effects that Numan and other colleagues have mentioned, you know, we know they have about 18%, 15% patient have dyspnea, and it's a twice-a-day medication. even from the cost standpoint, most of the stent procedures in Pakistan cost few 100,000 rupees, even if you do it in the public sector or a private sector, stents are expensive. So even if you have to spend a little bit of money in first 90 days using a drug like Anplag or ticagrelor, I think it's a very reasonable investment. So that would be my 2 cents, and I'm here. Thank you.
Thank you, Dr. Tayyib.
Fawad,
Certainly, there
very
wasn't any issue regarding the superiority. The debate is why we aren't really embarking on to this strategy of using ticagrelor. And since Dr. Javed Ashraf is setting aside you, so I'll give this opportunity to say a few words about it, and then we'll move on to Peshawar again.
Thank you, Dr. Fawad. Being myself new here in Pakistan, I think most of people are probably still not familiar with me. I am actually part of the Pegasus trial, and I'm still on their safety committee, a safety advisory committee, which continues until at least for 5 years. So honestly speaking, I could answer a lot of questions most people raised here. But for the time constraint, I think it is a time where we should, being a pure scientific person, I would like to say the debate which of the drug is superior, I think that debate is already over. Because just rightly, Dr. Tayyib said that it's now preferred drug in all the guidelines across the world for acute ACS. And if you probably have seen the press lately, now we have gone up to 5-year plus long-term safety data of the Pegasus. So coming to the whether we see stent thrombosis more here with this drug or less stent thrombosis, I think these are all well established. The risk is very, very minimal. It's all comparable. I'm talking about the TIMI major bleeding risk comparable to the Plavix. They're all have been well documented and stated almost a decade ago now. I think, yes, the question comes up here, the reason it's not been established or we are not using it, I think the reasons are number one, cost issue. I'm seeing it quite frequently, but as Tayyib said that we have to educate the community that it's the cost, how much in terms of the relevant cost compared to the other lifestyle. So we are happy to spend the thousands of the monthly telephone bills, but the question is spending how much we are willing on a roll. I think this is one thing we need to go out. One thing that we're using here, people are, yes, the Pharmavir did a great job doing the bioequivalency testing here to compare the Anplag with the Brilinta. But remember that all the other drugs, the cardiac drugs, which are using, almost none of them have a bioequivalence. And some people, when they come up to me or to other that, because we don't have a data in the Asian population, in Pakistani, in Desi people, like we call them in America, I'm afraid of using this drug in our population. They are small size, they are very different, but keep in mind, we use the ACE inhibitor, we use the ARBs, we use the Panadol, we use the antibiotics, we use every other drug. All these drug research have been done not in Pakistan. So this is the most important drug, not for the ACS, but even for the longer term, with this very good safety profile, which is equivalent to the Plavix and a better efficacy result. As Dr. Numan said, the curves diverge within days after the start of the medication. So why not? So I think it's the education to the people, not only to the interventional cardiologists, but to the general cardiologists as well as general physician and to the public. Thank you.
Thank you, Dr. Javed Ashraf, for your very nice comments. Now we'll move again to Peshawar. It's like a PDM Jalsa, so many leaders to speak. So now coming to Peshawar again, Dr. Ambar Ashraf, there is some koi sazish hai aapke mic ke saath.
Assalamu alaikum, Dr. Fawad. Can you hear me now?
Yeah, we can.
Oh, thanks God. वाकई कोई साजिश नहीं। और naturally मैं फवाद की जगह तो कभी भी नहीं ले सकती हूँ, ठीक है? Thank you. It's a wonderful program. Thanks a lot, Ji. You have given me an opportunity so many times. But I just want to, in a quick review, I just want to share a few of my personal experiences, and that's really important. Like when Pharmio launched this drug, we were all very happy. And from Peshawar, I gave the first prescription to one of my patients. I did her LAG fixed in 2011-12. Yeah, in 2012. And she is roughly 56 years of age, diabetic lady, and readmitted with acute coronary syndrome. That is some 1.5 years back when this drug was launched. I started her on the drug, and because she refused, मैंने दोबारा एंजियोग्राफी नहीं करानी और कुछ भी नहीं करना, just treatment with the drug. And the response was so wonderful, which gave me a confidence and strength. Yeah, it's a good drug, and so gradually, especially the non-STEMI elderly patients where we are managing and they refuse to go for the intervention. Personally, I'm using the drug, and what I'm using to do with that, the 90 milligram tablet, I make it off and make it BG, and it look after their bleeding side as well, and symptomatically they are doing very well. No drug, no doubt, the drug is costly, but if they are using so many drugs, and we can give for 2 to 3 months, and then we switch over to clopidogrel as well. So it was a wonderful debate and wonderful experiences. All the galaxy of cardiologists all over the Pakistan have shared. But the good thing is, after such a long time, we meet all the people from Karachi, Lahore, Islamabad, and even from the Peshawar people. That is the only way in which we connected nowadays. Or Dr. Fawad, कोविड की सिचुएशन पेशावर में, लाहौर में बहुत बुरी है. आप कराची में बड़े सेफ हैं इस चीज पे. अल्लाह ताला सबको अपने हिफ्ज़ अमान में रखे. And that's why I'm doing it from the hospital with the mask. And सादिया अभी आइसोलेशन से आ रही हैं वापस राउंड करके. And there are more than 120 patients. And day by day the situation is becoming worse. So important message on that platform is, please ask all your cardiac patients, diabetic, hypertensive, to get vaccinated. It's just like a seat belt, and it is the need of the day, as well as we are treating the rest of the thing. A session debate which has highlighted so many issues, and you have this bioavailability testing as well. Thank you for giving me an opportunity, and thanks a lot to all of you.
Thank you, Amber. And there is one more participant left from Peshawar, Dr. Asghar Khan, the last one. Sir Asghar Khan, जब बड़े लीडर होते हैं वो आखिर में खिताब करते हैं.
जी डॉक्टर असगर बहुत बड़े लीडर हैं हमारे, इसमें कोई शक नहीं. He belongs to a very nice, strong party.
Okay.
He's a wonderful.
Yes, Asghar.
Thank you very much for invitation. Ticagrelor is more effective than clopidogrel proved. In plague is equal to Brilinta proved. The question was always about its safety. It causes more bleeding. So what to do with it? The Twilight and the TICO trial tried with monotherapy after 3 months, and it therapy. The Themis trial in stable ischemic heart disease showed to be more efficacious than clopidogrel in the long term. But again, the bleeding, although the bleeding were not very serious, the issues were basically in PCI patients with Twilight and in thrombolytic patients in recently with TREAT trial. The patients who were received thrombolytics, even in developed countries and in our part of the world, majority of our STEMI patients we treat with thrombolysis. So the TREAT trial addressed this question, and they gave this ticagrelor versus clopidogrel within the first 24 hours after thrombolysis with an average of 11 hours. And they proved there was basically safety outcome trials. Both the Twilight and this TREAT trial were the safety outcome trials. So with thrombolytics, the TREAT trial showed that the ticagrelor is non-inferior to clopidogrel. So my question to this galaxy of leaders of cardiology would be that can we design a study like the Clarity. After the Clarity, the loading dose of clopidogrel started before thrombolytics. So if we have the courage and not to be afraid of bleeding, can we load our patients, because still a lot of our patients are dependent on thrombolysis for their STEMI management. Although they may go later on to invasive strategy, can we design a strategy of loading them with ticagrelor, followed for at least 1 month, and then de-escalate them to clopidogrel? So this will be my question to all of you for a multi-center trial, if you do agree to it. Otherwise, in PCI, of course, in STEMI and ACE patients, Nplate is superior to clopidogrel. Thank you very much.
Thank you, Asghar. I think there are a lot of things need to be discussed. Its usages, different scenarios, even the patients who are kept on conservative measures, should we be using ticagrelor in place of clopidogrel? Those who are receiving thrombolysis, should they be on ticagrelor as compared to? And these all are there in the data that it has shown at least non-inferiority and in some situation even superiority with some additional bleeding, but certainly need trials. So with that, I think we have concluded, and for lastly concluding remarks,
I just अगर
try
आप
on
इजाज़त दें,
us, yeah,
आप काफी strict हो गए हैं senior होके.
Actually it's the time, 4:15. No, sir.
चलें, होता है, कोई नहीं. As an answer to the fact, we did publish this study. I shall ask the PharmEvo team to, propagate this study with the doctors who are present and otherwise as well. I just have a question, and this question to very senior people sitting on my right. We have a significant subset of patients who need anticoagulation along with dual antiplatelet therapy. So in that case, what is your choice of dual antiplatelets, and what is the choice of your anticoagulant? Because I had a patient yesterday with DVT, and he had a primary angioplasty as well. So your views about ticagrelor and with anticoagulation, Professor Tariq and Professor Tahir? And anyone, please, anyone from the galaxy of cardiologists, please.
I think that's totally, Dr. Faisal, again, aap bura maan jayenge. Actually, it's a subject you can go on and on and on. There are volumes to speak on everything. So since we are short of time, it's already 4:15, but we'll take that comment from Professor Dr. Tariq Ashraf regarding that, the use of triple regimes, and they are different according to the bleeding and thrombotic risk. 1 week, 1 month.
Ticagrelor has no data with
in triple therapies with direct oral anticoagulant, warfarins, you have to use clopidogrel. Certainly when you are going to dual, you can switch to your direct oral anticoagulant and ticagrelor, omitting the aspirin out of it. But there are different strategies, and these all certainly on according to your thrombotic risk and bleeding risk kind of procedure. Or other way, if Dr. Tariq want to add something.
I think you are right, Fuad. And this depends upon the bleeding risk and the thrombotic risk of the patient. So somebody will continue on clopidogrel with a low dose of aspirin and with NOACs. And if you're continuing with ticagrelor and ticagrelor with NOACs, so it depends upon.
And there are situations where even you can't use NOACs,
yeah, there's no
because if patient has a prosthetic valve or something additional on and using triple therapy, then you have to go for warfarin as well. Now we are going to conclusion of. Yes, anyone want to make a comment?
There's a comment from all consensus that with DOAC would avoid using ticagrelor because of lack of data and very rare. So if you're using DOAC, would use Plavix with that, and also reduce DOAC dose with the rivaroxaban like 15 milligrams instead of 20. Just a comment with that.
Agree.
But would avoid ticagrelor with any DOAC.
Okay. So if we have with us Professor Hafizullah sir, finally conclude the session. Do we have Professor Hafizullah with us? Okay, then we can request Professor Shehbaz Qureshi sir to please conclude.
Thank you very much, Professor Fawad. I think it has been an excellent session, and I would like to congratulate Farmivo for their excellent efforts in arranging this great debate. And as Tayyab very rightly said, that basically, as far as the debate is concerned about the use of ticagrelor, it is over. It is already a class 1 indication. And I agree with Noman when he said that if you are using direct oral anticoagulants, in that case, actually you do not use ticagrelor. That is what the data says. And I think the comments from all the panelists were excellent. They did a good job, and I would, in the end, congratulate Fawad for moderating it really very excellently. He gave adequate time to everybody, and everyone actually made the expert comments as and when they were required, and they were really very good. And I think this should be available to all of the cardiologists in Pakistan so that they can actually use this as a kind of a stepping stone to break the inertia in the use of this new and a novel drug, which is very useful in patients with acute coronary syndrome. And as I said earlier on, ACS actually is a very, very serious condition and should be managed properly. And we should all be we should consider the side effects of the drug. We should think about the bleeding profile, and then as we go about using it, we should de-escalate it after a year or so and start using clopidogrel. Once again, I would like to thank Farmivo. Thank you very much.
Thank you.
It was really an excellent, and I learned a lot from it.
Thanks, Professor Shehbaz. And now I hand over the proceeding to Masood Javed for vote of thanks. Over to Masood Javed.
Thanks a lot from all the worthy participant galaxy of cardiologists and interventional cardiologists all over the Pakistan. And it's a proud privilege for us as Farmivo to host such events and evidence-based working as well as evidence-based debate over the different issues related to both efficacy, cost, and our culture thing. And by looking at those things, as it was pointed out, to do some more research studies related to those kind of things, like initially one medication, then change over to it. So at an organization, we look forward to supporting such initiative and also starting. And we are also very thankful for Dr. Naghma Hashmi for conducting that study for us and presenting their results. Fawad Farooq for excellent moderation of the session and making sure that we'll end at the time as well. And thanks a lot for the excellent experts and their comments. Thanks a lot for all of you. Hopefully see you all of us face to face after the COVID era. Okay.